ovulating, maybe you're not. Maybe you're estrogen dominant, maybe you're not. Like, you've had issues up and down, and then like, well, where does perimenopause really start? Like, how do you define the difference between young and now there's something else going on?
Right. Unfortunately, again, we need more studies. We don't have good blood tests in perimenopause to say you are perimenopausal, and so many of the symptoms look like other stuff. So when I have a patient coming in and she's like, something's not right, okay, I would have to rule out I'm ruling out hypothyroidism or autoimmune disease. I'm doing a lot of blood work, nutritional deficiencies, anemia. We're doing an iron workup because those are the things I want to make sure we're not missing before we start talking about therapy. So most patients with PCOS now are offered a birth control pill to cover their symptoms, and that's what I was offered, given, and actually did pretty well on. Okay, because we are trying to suppress the ovary with. So the big difference between birth control pill and menopause hormone therapy is dose. Birth control, hormonal contraception was developed to stop ovulation, so that's like up here. Okay, we need this much to send a signal to the brain saying, shut it down, we're good. Because in order to ovulate, remember the hypothalamus talks to the pituitary, sends all these chemical signals to the egg. So the ovary's just sitting there waiting to be told what to do. And in PCOS, the patients are, like myself, I had the thin kind, so there's like the heavier kind, the thin kind. We're insulin resistant, it's basically the pathophysiology of that. And so all that extra insulin is making our ovaries more resistant to signals coming from the brain. That's how it works. And so, it's complicated, and most docs don't have enough knowledge to be able to. And so menopause hormone therapy and perimenopause is the lower dose, not enough to suppress a natural ovulation, but enough to tell the brain, calm down, we're good. Like, there's enough here to keep you going. You don't need to send all these crazy pulsating, super high symptoms, which is why we see these dramatically increased levels in perimenopause of estrogen, and these women are getting diagnosed with estrogen dominance, which is not a medical term, it's a marketing term. So, medically, people having oligoovulation or anovulation, like infrequent ovulation or no ovulation, can be due to multiple things: hypothalamic suppression, starvation, super thin, PCOS, or perimenopause. And it gets really tough sometimes to tease out.